Hello, everyone. Yes, indeed. I'm going to share with you our outcome, the outcome of study on the practices and challenges in antibiotic prescriptions in Niger and Uganda. Now, antibiotic resistance is a critical public health challenge in children with serious drug-resistant infections responsible for a significant mortality burden, especially in LMIC. This is due to the lack of new antibiotics in the pipeline for priority infections and also very few pediatric antibiotic development programs. Now, the Global Antibiotic Research and Development Partnership, GARD-DP, created by DNDi and WHO in 2016, is a non-profit-making organization that wants to come up with new treatments for priority infections in partnership with public and private sector players. GARD-DP has got a project for neonates and pediatrics, and they funded a study in order to learn more about antibiotics in low-income countries in order to better understand the treatment with antibiotics of children under 18 and to better understand practices when it comes to antibiotic prescriptions by healthcare professionals, and also identify the constraints and main elements that have to be improved and simplified for antibiotic treatment of children. So, four structures in Niger and Uganda. We included only general pediatrics, either in OPD or IPD, and in the rest of my presentation, I will just call these structures N for Niger and U for Uganda. This is a mixed qualitative and quantitative data study with a retrospective quantitative study during which we collected prescriptions over 2 days per month between January and December 2019 on basis of clinics registries and also patients' records in IPDs. And for qualitative assessment, we carried out semi-structured interviews with healthcare professionals, doctors, nurses, pharmacists, and also we had group discussions with children carers. Now, here are quantitative results in Niger. 660 clinical records, majority of children under 5. Injectables, very few, in fact, were prescribed. More than half of these children had combined antibiotic treatment in hospitals of the highest referral grade, less so in OPDs. And with regard to the most frequently prescribed antibiotics, oral amoxicillin in healthcare centers of N1 structure, ceftriaxone in the injectable form or alone, or combined with gentamicin in hospitals from N2 to N4. And this association is not the one that is recommended by WHO. In Uganda, we included some hundreds of clinical records from various structures, either OPD or IPDs, majority under 5. Injectables were usually in hospitals, usually in private U2 structure, and the combination was conventional 1 ampicillin plus gentamicin, or less conventional ceftriaxone plus benzylpenicillin. In the regional U4 hospital, the proportion of combined antibiotic treatment was lower, with a first line of treatment that is, in the majority of cases, ampicillin. Asking prescribers about their practices in Niger and Uganda, we came to understand that they don't really rely on laboratory data because of the cost and lack of availability. They're also faced with a lot of constraints because there's a lack of nurses, so they have to reduce the number of doses per day. And a doctor in Niger explained that ceftriaxone was easier to administer versus ampicillin or cloxacillin, because these two have to be administered 2 or 3 times per day. But because of the lack of human resources, we had to drop them. There's also unreliable supply, and doctors have to take into account what is available in the pharmacy. For instance, a health worker in Uganda told us, well, if you do have ampicillin, and it's the only thing you have, well, this is what you give. And it's also influenced by financial means in the families. When antibiotics are not available in the pharmacies, at the hospital, well, the families get a prescription and they are asked to buy these antibiotics from the chemist. And sometimes because they don't have the means to pay for it, well, we have to turn to the oral route again. In Uganda, where the private health sector is more extensive than in Niger, the healthcare professionals told us that they are under pressure. These sales reps come directly to the hospital, and in fact, they give drugs to those people who are ready to prescribe them, and they try to convince you that their antibiotics are better. Some carers also argue that it's very difficult to give pills or syrups, so they rather use dispersible pills. And also carers explain that they get very little information on treatment from doctors. Self-medication is quite common. A mother told us that she buys amoxicillin, and whenever the child has a cold or diarrhea, she gives ciprofloxacin or amoxicillin, and they buy directly from the sellers. However, families are aware that buying antibiotics from private pharmacies or private sellers can be risky. And according to study participants, the main improvement would be to get access to pediatric formulae, such as oral dispersible pills, also getting something more adapted in terms of dosage, also strengthening the guidelines and updating them regularly, also training the healthcare professionals and raising the awareness of patients about the good stewardship of antibiotics, and also improving access to lab tests in order to decrease antibiotic resistance. There should be also more control in the regulations that govern the antibiotic prescription. And there's also the fact that there are no rules for under 5, so we need to have a better stewardship of antibiotics in low-income countries, is to assess the impact of measures that are put in place to improve the stewardship of antibiotics. Now, there's no monitoring in healthcare structures, and of course it would be necessary to get a better commitment from pharmacists. Finally, there are several constraints for healthcare professionals. And it's very difficult to have a good stewardship of antibiotics. And the development of new antibiotics for pediatrics will have to take these complex situations into account, and namely with regard to cost, formulation, and number of doses and access to these drugs. I'd like to thank my colleagues in Niger and Uganda and Paris, and also the GARDP teams and their partners. Thank you.